When Dr. Justice called me a couple months ago to consider speaking as a wrap-up, I think as people know in my section, I'm one of those, I think by the Myers-Briggs, called the INTJ. I'm relatively introverted, so coming up and speaking here does always make my heart rate go above 100, but I'm glad that we can't measure that yet. And I have to say this morning, just sitting and listening to, I've had the pleasure of listening to Dr. Sullivan's talk, which I found was really inspiring a couple months ago. Listening to my colleague Survit Chowdhury talk about some of the work they do, some of the other initiatives that are going around here, is just, I find, really inspiring and exciting. And as I was talking with Amy Justice a couple minutes earlier, you know, I have to say, though, I don't think that 5 years ago that we would have the same kind of audience and enthusiasm for electronic media that we do today. And why that shift has happened, I think, is something that is worth considering as an audience. And let me just give you an example, and then I'll kind of back into, I've actually taken 7 pages of notes this morning, but I won't go through all of them. But I think there are some important points to consider as we go forward in this medium, depending on how you want to use it. And each of you are clearly using it in different ways. And there are challenges and opportunities associated with each of them. So just 2 kind of little tidbits. 5 years ago, I got a call from an editor at a major medical journal. And that editor asked me if I was interested in moving to that city and becoming a part of their journal as part of the editorial staff. And I said I was only interested in it if they considered really sort of containing a more media-friendly component in the journal. At that time, journals were still largely what came through your mailbox, that if your dog didn't chew it up, you were lucky that it survived. Online had still really become something that was viewed as secondary. And I said, you know, a sort of multimedia in terms of interactivity, even if it's, you know, it's not only researchers, but it's the patient community at large, is something where I think the journals are going to be going. And I think it's a presence that, fill in the blank, you want to be. And the editor said no. And lo and behold, the major competitor of this journal editor, about 2 years later, launched a very, very aggressive, multidimensional sort of media type of interactivity on their journal. And I just thought, you know, I'm glad I didn't move because I really love here. But I really think it was a lost opportunity in terms of sort of what different forms of media can do that can be accessible not only to us as researchers, but to patients and the public at large. Because I think part of the next step in terms of what the next media conference is going to be is how do you take tools that you're using in research, products that you are creating that are using media, and make it more accessible to a public and to the public, to people who don't have kind of the level of education that most people have in this room. So that was the first little piece I wanted to throw out, and that's really shifted. I mean, you look now at the New England Journal of Medicine, and they have video conference lines, they have audio, they have interactive clinical correlations. Every week I'm just astounded at kind of what they offer that didn't even exist 5 years ago. And furthermore, it wasn't something that we as a culture thought we should provide. And that's been a shift. Now, I'll go back to my life this weekend, where I'm a general internist, and I was on call for my practice. And I was in clinic on Friday afternoon in Waterbury, which is with a largely underserved patient population, many of whom don't speak English, many of whom do not have homes, but interestingly, almost all of them have cell phones. And you all know this now because many of you use cell phones in your work. And not only do they have cell phones with cameras on them. So I'm sitting here thinking, how can I be more efficient in my patient care? And you can consider thinking about opportunities using cell phones and cameras as a way to really work with high-risk patients. What if we videotaped every medical 15-minute counseling session that you had with your patients, and that video could be put on their digital, on their phone, and they can take it home and watch it, as opposed to giving them a form, which never goes anywhere other than into a bag. So that was one thing I thought about, that I've thought about consistently as a provider. I was also on call this weekend for my clinic. And I have to say, who do I get called from the most besides the emergency room? It's visiting nurses. Visiting nurses who basically call me. They've had a patient who's been discharged from the hospital. They have no idea what meds the patients were on and are on now. And even though there's a really long W-10 or a form, they don't really know. And that's really sort of, I think, what Dr. Chaudhry alluded at today, which was that media is really underutilized in care transition points. And we're now technologically at a place where you can, 5 years ago, media was too expensive to do this. You know, you didn't have, you had much more issues related to storage technology, size, and now you've got, frankly, everything is digital. You can put a terabyte of material onto a drive for less than $50. So why can't VNAs actually, why don't we videotape all hospital discharges? I mean, we don't have to videotape some of the more issues related to sex. I'm going to stay away from that. But thinking about some of these moments in time where the audience is largely just about patient and provider, or and yet there needs to be more people who need to be able to see those interactions. That's where electronic media, I think, really has a number of fantastic opportunities that we as providers or researchers could do. So those are sort of my ideas that I thought back there today. But there are other issues which, because since the title of my talk is Challenges and Opportunities, that I think we should all consider as we move forward. And themes that I wrote down today. Why is electronic media why are we here, and why would electronic media be different as opposed to, let's say, a conference on just media and health? How are those two things different? And I think they are different. Media, when I started in media, was very much sort of the traditional bricks and mortar model. People watched television, networks controlled what the message was, it was broadcast on the screen in your home, and it had a very sort of set way of who controlled the message, and I think that's also similar in some ways. That's how it shifted in medicine as well. Who controls the message, who controls media has shifted. So one thing I think about that we have in terms of the media now, interactivity. You know, the media has a means in terms of making basically your experience in healthcare much more interactive. There's a porousness that media can allow that often other current systems don't offer our patients. You see that somewhat in electronic medical records, as a doctor from the VA, Dr. McInnes, talked about earlier this morning, but it's mostly email. So can potentially you now change that so you have other types of information that patients can interact with within systems that we have. The media isn't instantaneous. That's something that's changed in terms of what healthcare can provide patients. It can be, for instance, as a patient, I would still really like to be able to access my lipid level next week, have it texted to me instantaneously. That current system doesn't exist. Even within the Yale Health Plan, as you know, you have to email your provider and kind of ask them gently for the result, and they might send it back to you, but generally you're waiting. And yet most of us in this room this morning have texted someone, we have gotten 2 or 3 voicemails, and so there's an instantaneous component that I think we have not yet sort of brought into what we do in our research and educational tools for patients. Why is that? I think some of it is in terms of what our skill sets are. We're not trained as media makers. You know, usually when I go to research a topic, I go to PubMed. And that's a very different type of information that's given to me as opposed to, let's say, I'm a producer for CNN and I want to create a program on HIV education. Those type of skill sets are very different. And I think that's learning those type of skill sets are things that we're going to have to do as we go forward. Other issues that I think in terms of where, and it's clear today that people use the media as or aspects of the media either to study different patient populations or tools to engage with patients at times in their life when we don't have access to them. So, for instance, looking at high-risk behavior, most of us never have access to that in our patient sort of traditional model of an exam room. You don't know how access behavior occurs, so we create technologies so that potentially we can interact with them. But I also think there are places in the healthcare system where we could consider using media in ways that actually might make us somewhat uncomfortable. So consider how actually we train physicians and how patients interact with physicians. Most of how we even train surgeons, internists, none of it is measured. We don't know anything prospectively about performance. You could consider videotaping or audio taping all of our informed consent with our patients. When I mention that, usually people get somewhat concerned. But this is sort of an area where I think the media is going to move because it's pretty much it's so portable for patients. Other areas in terms of and this raises whole issues of privacy and ownership, which I know Dr. Carroll talked about today. Who owns products that you make, but actually who owns patients' data? Who owns patients' experiences? Up until now, for the most part, we've assumed we've owned it. We've assumed how we disseminate this and how we transmit this, but that's changing. If you look at, there was a piece that Time Magazine wrote on Mayo Clinic about 2 years ago where actually they had done a study on patients with celiac disease, and rather than traditional mortar and bricks method, whereas journal publishes study, releases it to media first for a week, media has a week to sort of chew on it, media calls you, researcher interviews you, and hopefully you end up on the cover of New York Times or NPR or McNeil-Lehrer, and then your employer is very happy with you. So what Mayo did actually was they released the study findings to their patients who participated in the trial first. And then they released it to the media. So you're beginning to see organizations using media as a way to share information with patients. I think in the next 5 years, that is very interesting. It's quite controversial. And Professor Adelson this morning sort of stole my thunder because he talked about patients like me, which I think is one of the most interesting health sites and use of media by patients that is not only controversial, but it's quite innovative. And for those of you who knows about patients like me? Okay, for all of you, I would spend just 10 or 15 minutes. You're stuck in an airport, you're delayed, you have nothing else to do. It was started back in 2004. It's interesting how it got started by 3 brothers who were MIT engineers. Their oldest brother had ALS. Anybody who's ever spent any time with anyone who has ALS knows pretty quickly, because there are absolutely no therapies. Often patients will go to the internet to really look for therapies, look for support, and I think that's what patients often do because they feel so isolated. But they created a website for patients with neurological disorders, unlike many other websites, patients often will submit their names, they'll submit their age, they'll submit their symptoms, and then they can compare different disease symptoms with different types of drugs. So a patient with depression, let's say, who has not responded to Prozac or Celexa, can find that if they share their certain symptoms, that maybe Lexapro works better for them. And they have, I think, as of last count, over 100,000 registered users. First it was mostly neurological disorders, and now they've moved to other disorders where the therapies are sort of less defined. And it's very interactive. Patients are very comfortable with being exposed, they're much more interested in transparency, and it makes researchers very nervous. Not surprisingly, as you can imagine, potentially you're thinking about how can patients be exploited with this. And who's doing all the data mining? That's another question. It's mostly pharma. So, and patients like me is not the only type of sort of electronic media, patient-empowered types of websites. You pick some of the rare disease conditions, brain tumors, diabetes, many of the stigmatized conditions, you can find that all online. And so I think these are some of the next steps and questions we as researchers, what if you have patients who want more ownership in the research process, if they're more comfortable with transparency, even if they verbalize being aware of the risks, how much of the role should they play in their care? And media is a place where you begin to see that interactivity happen more than, let's say, just the chart. The chart is largely retrospective, it's largely text-based, it's largely one-dimensional, and the media allows you to change that interaction. And because that moves up into more than one dimension, I think it produces a lot of discomfort. The other piece, too, is what are you going to do with all this? You know, it's great if you have a terabyte worth of video material, or you have hundreds of hours of audio tape material, but you know, where are you going to store it? You know, who's going to analyze it? Anytime you look at type of media information, it's very messy, and what we've done for now, for the most part, we sort of parked it into continuous quality improvement, which means that if there's something that we videotape or record that makes us potentially uncomfortable, meaning i.e. error, or not so professional behavior, we just erase it. And which is true. It's what a lot of the trauma services do. They just erase the tape after a week. But now digital has made it much harder to erase. So, so what do you do with these issues of potential exposure of behavior on the part of either provider or patient, where it's not so clear it's about sort of the best possible care? So, so these are some of the issues that I kind of chew around in my head and think about. I think it's fabulous that we're using media as we go forward. I think there are more ways that we can use media that will involve patients, and I think particularly as the technology evolves, just as an example, a high-def video camera, and high-def up until now was largely what Hollywood used. A high-def video camera is less than $700. You can buy a little camera you can put on your head if you're like a mountain biker for less than $150. So you really have a compression of what is accessible to the public, and so I think that's really exciting. But I think there are issues that we have not really yet to address. I'll say one more example because I think this is really interesting, and then I'll stop. This appeared on ABC News in December of this year. There was a couple in a hospital in Pennsylvania who had wanted to videotape their the delivery of their fifth child. In the hospital, they wanted to sort of record this event as something for posterity, and the hospital basically said no. The hospital said they could start videotaping 5 minutes after the APGAR scores had been collected. And this created a huge firestorm of controversy. As you can imagine, Brian Williams did a story on it, and then of course if you look on the NBC website, there were hundreds and hundreds of responses. And so again, it sort of tiptoes into the issue of who owns media, who owns the patient's experience. If information that relates to a patient's experience is viewed as research, how should that be disseminated? So I don't have the answers to all of these, but I think these are sort of issues that we need to wrestle with as we go forward. As a physician, would I be comfortable being videotaped on all my hospital rounds? I don't know. I don't know about that. But I think those days are coming because technology is portable and smaller.